I am Dr. Kim Youngjae, Director of the Korean Dental Hospital. Last time I gave a lecture on central occlusal contacts. Based on the holding cusp, the holding of the upper and lower teeth constitutes the maximum intercuspal position, and I discussed how that maximum intercuspal position performs mandibular holding. If the mandibular holding is disrupted, various occlusal disorder symptoms occur. These days, there is much discussion about full-body occlusion. When there are issues with full-body occlusion, the body aches in various places and mental problems also arise. We often see patients whose condition deteriorates rapidly for unknown reasons and continues to do so. There are also such cases. There are patients, especially young ones, who suddenly experience physical pain, look for the cause, discover that there is an occlusal problem, and naturally become interested in occlusion and seek help. So I will talk a little about that. Here, I use the term occlusal adjustment, but it is more accurate to view it as an occlusal disorder. When explaining to patients with systemic occlusal disorders that their condition is simply due to poor occlusion, patients find it difficult to accept. You need to clearly describe the exact state of the patient's occlusion and the situations that have been caused by it. I believe that by providing such detailed explanations for the patient to understand, they will agree to the treatment. If the occlusion is poor, is it malocclusion? When considering whether the patient is actually experiencing pain due to the problem, having malocclusion does not automatically result in systemic occlusal disorders. Of course, malocclusion patients may develop respiratory disorders and postural issues, but malocclusion and pathologic occlusal disorders are different matters, because malocclusion can be regarded as an acceptable occlusion in itself. Therefore, correcting malocclusion does not mean that the occlusion is mismatched and needs adjustment, but rather, because the occlusion is established in an incorrect manner or under incorrect conditions, we disrupt that occlusion and create a new one. Why do systemic malocclusion disorders develop in some cases but not in others? In seeking to answer this question, I have given it further consideration. The holding cusps interlock with each other, preventing an all-square alignment, disrupting mandibular holding, and making the position of the mandible extremely unstable. This instability leads to the instability of the temporomandibular joint, causing patients to have difficulty swallowing and disrupting overall balance functions such as body regulation. As a result, patients become aware of these symptoms. If this anxiety persists, it can lead to various health warning signs, including insomnia and hormonal changes. Patients struggle with these issues and ultimately come to the dental clinic after identifying the cause. Before visiting the dentist, patients usually undergo various examinations. They receive MRI, CT scans, and psychiatric treatment. Even after numerous tests fail to identify the cause, they ultimately come to the dental clinic, having typically undergone various other examinations beforehand. Then, I examine the oral cavity to check whether the holding cusp is properly engaged and whether the centric concept has not been disrupted. For example, patients with class 2 malocclusion have their jaws continuously pushed backward, causing the mandibular molar to press against the TMJ. Such conditions also need to be assessed. When the all-square is disrupted, the mandibular position changes, leading to various symptoms such as increased anterior guidance. The direction of treatment is determined based on how I interpret these symptoms. Additionally, they are amplified by lever action. For instance, persistent class 1 lever action, or the jaw being pushed back at the moment of occlusion due to class 3 lever action. Through these various processes, patients may feel that the balance of their jaws has been disrupted, or that the stability of their maximum intercuspation has been lost, causing them to feel a disruption in mandibular holding. They tell me about these symptoms. However, I am neither a psychiatrist, nor a tuna therapist, nor a rehabilitation medicine doctor. I am just a dentist. Therefore, I have no choice but to provide dental treatment. When I think of it as a systemic occlusal disorder, I look for and treat the causes of this condition, which I consider to be diagnosis and analysis. And with such analysis, I proceed to treatment. What we have misunderstood so far is that when systemic occlusal symptoms arise, we often thought that the patient sought a dentist because their occlusion was high. So, we ultimately chose occlusal adjustment using the negative method. And performing occlusal adjustment using the negative method means removing material. It might be more accurate to describe this as subtraction. There are negative and positive methods. The positive method involves adding something to the occlusal surfaces or the shape of the teeth for treatment. By removing the shape of the teeth in this way, there is content regarding occlusal adjustment, specifically occlusal reduction. One of the reasons why most dentists choose this method is its simplicity. High-speed diamond burrs or low-speed stones are used to grind the occlusion. If you have a knife, you naturally want to cut. If you hold a saw, you naturally want to saw. And if you have a hammer, you naturally want to pound. When the means available to you are limited, you have no choice but to try them. Therefore, I have often seen cases where attempting to solve problems through occlusal adjustment alone leads to bigger issues. Therefore, I recommend using this method. The idea is to use both subtractive and additive methods together. Reducing the maxillary arch and performing restoration for undercruising is necessary. Next, if there is posterior occlusion coming down, reduce the posterior occlusion, remove prematurity as much as possible. I believe that designing a treatment approach that levels the occlusal plane is the correct method. However, dental schools only continue discussions on occlusal adjustment. Under the premise that balancing prematures must be eliminated, defining balancing prematures as negative, removing them disrupts the centric occlusion. Treating in that manner makes the problem more serious. So, we must consider whether such balancing prematures arise due to the position and angle of the teeth, or due to the direction or inclination of the teeth, or if they are simply high. Of course, if the prosthetic restoration is high, it is appropriate to reduce it. However, in such cases, I believe that performing orthodontics, or preserving the existing condition, helps maintain the patient's jaw position. Yet balancing prematures are consistently taught as problematic in a didactic way. Because they are harmful elements, they must of course be removed, and we teach that they should be ground down and eliminated. Although that method has been overly emphasized, there are times in clinical practice when it cannot resolve the issue. Therefore, I believe that such occlusal adjustments should be addressed by adding restorations. But patients often fear this treatment. Both dentists who need to perform the treatment are apprehensive, and patients are often reluctant because it frequently requires tooth preparation and the placement of a crown. There are times when it's difficult to persuade patients due to the costs involved and the common perception that removing teeth is bad. You should not try to force persuasion. If the patient does not want to have teeth removed, there is nothing you can do. If you force such treatments and the problem is not completely resolved, the patient's trust will rapidly decline. You should not confidently push treatment onto the patient, believing that it will be entirely successful. Even if the symptoms decrease from around 100 to 50, from the patient's perspective, 50 remains. Since the symptoms remain but the teeth have been removed, the patient may feel aggrieved. Because they might judge that the treatment was done incorrectly, never force treatments. Of course, you should keep thorough treatment records in the chart. However, don't create situations where you end up arguing with the patient due to forced treatments. Be cautious when recommending treatments that the patient is hesitant about. The cases I mentioned are general cases, and when such patients come, I sometimes recommend orthodontic treatment. For occlusal reconstruction, full mouth rehabilitation is also recommended. This should never be performed without the patient's consent, because this is an irreversible treatment method. If the patient does not consent to the treatment, I recommend first using occlusal splint therapy to see if the symptoms improve. Occlusal splint therapy includes CR, CO, and pivot types. If only the vertical dimension is altered, the patient's symptoms significantly improve. I use occlusal splint therapy diagnostically to first analyze the symptoms. It is a simple prescription aimed at alleviating the symptoms. If occlusal splint therapy is effective, then proceed with full mouth rehabilitation or orthodontic treatment. And if there is a jaw problem, orthognathic surgery must be performed. Recently, those who have used orthodontic techniques that induce growth through force by using extraoral headgear argue that orthognathic surgery is not necessarily required, but I do not completely agree. There are quite a number of professionals who have focused exclusively on orthognathic surgery. When surgery is presented as necessary, It's as though it's labeling someone as bad. They argue that good treatment can be achieved without surgery. While such arguments can certainly create a positive impression for patients, if the patient does not cooperate with wearing devices, ultimately, the issue must be resolved through surgery. So I believe both perspectives are valid. It's somewhat of a political statement, but when you consider it, both sides are correct. Next, periodontal and prosthetic treatments are approached from the perspective of occlusal rehabilitation. We have extensively discussed the holding cusp concept, and the next considerations involve the centric concept, vertical dimension, and eccentric concept. When examining occlusal rehabilitation first, there are eccentric concepts. Should we refer to it as canine guidance or as group function? There is also much discussion about balancing. There are many dentists who are very sensitive about eccentric guidance. I believe that eccentric guidance is a choice. I think the centric concept, which is the prime factor, is inherent in maximum intercuspation achieved through the interlocking of the centric holding cusps, and the eccentric concept inevitably becomes a choice. When considering class 3 occlusion, anterior guidance and overbite do not form in the anterior region. Thus, canine guidance cannot be achieved. I believe bilateral balanced occlusion is likely the occlusal pattern for patients with class 3 occlusion and prognatism. In the case of class 2, anterior guidance prevails. Additionally, group function and canine guidance occur at roughly equal rates. This can be seen as a map guiding the direction of my treatment. It is a diagram that can be viewed as the coordinates for treatment. When performing treatment, I use this as a reference, set the direction in my mind, and find the path. Although I do not possess great abilities, when patients come to me, I at least understand these concepts and provide the treatments I am capable of. There are also cases where I refer patients for orthognathic surgery. Although it is not mentioned here, we also recommend tuna therapy. If necessary, we collaborate with other specialists to resolve the patient's problems, which I believe is the right approach. I think many of you will agree. We must provide treatments that benefit the patients. Delivering effective treatments to patients is also beneficial for dentists. It enhances our professional pride and self-esteem as dentists. There is also a sense of satisfaction and happiness that comes from alleviating the patient's pain. Therefore, I hope you will treat your patients with dedication. Ultimately, effectively treating patients is the most important aspect for dentists. Next, we determine the centric occlusion and maximum intercuspation positions, then select eccentric tooth contacts and guidance. Some may be sensitive to the term selection, but when considering overbite and overjet, the term selection seems appropriate. It is logical and scientific. It's the concept of whether the teeth make contact or not. When moving the mandible from centric to eccentric positions, during free mandibular movements, there are areas where the upper and lower teeth come into contact, and areas where they separate. However, we often think in a dualistic manner. When tooth contact occurs during eccentric movements, those that are advantageous are regarded as guidance, while those that are disadvantageous are seen as premature contacts. However, these two contrasting concepts both refer to tooth contact during eccentric positions. Therefore, both guidance and premature contacts are considered tooth contacts, and whether these contacts occur sequentially is the question. Or, do you suddenly make contact on only one side? When considering this, sequential contact is referred to as guidance, whereas having only that area contact first is considered premature. Furthermore, during such a process, the uniformity of mandibular movements is disrupted. Such factors cause excessive occlusal load, ultimately leading to the destruction of periodontal tissues. These occurrences are common. Because periodontal tissue destruction occurs frequently, premature contact is considered detrimental. However, uniformly and sequentially contacting should be regarded as guidance. Therefore, I view this as a concept of relative height differences. There are also incisors, canine guidance, premolars, and molars. You can see that incisors and canines are relatively elevated. Therefore, in cases where teeth are not worn, canine guidance or incisor guidance is appropriate, because they are relatively higher. And let's examine class 1, normal occlusion cases. There are such cases. The occlusal plane has become canted. Either it has tilted upward or downward. When the mandible moves upward, the upper side becomes weaker, while the lower side strengthens. When the teeth guide to the right, the working side lowers, weakening it, and when moving to the left teeth rise, strengthening the guide. Thus, the shape of the jaw also undergoes deformation, according to the deformation of the occlusion. I believe that depending on the canting or the state of the occlusal plane, areas of relative elevation emerge. This was the initial concept. Consider the light blue as premolars and designate the red as molars. As you can see, this has been integrated into a single image. You can observe that the incisors are relatively elevated. The light blue premolars are in the middle and the red molars are lower. I only illustrated one anterior tooth. This is the holding cusp. At this point, if the mandible moves toward the working side like this, anterior guidance becomes inevitable. It is a natural result. If this angle is greater than the balancing angle and incisal guidance takes effect, the mandible retracts significantly, resulting in no balancing premature contacts. Thus, there is no balancing tooth contact. Then, when the buccal guide is reduced by the premolars, contact is achieved. Next, as tooth wear occurs even on the molars, further lowering the buccal guide, eventually balancing contacts are established. In fact, bilateral balanced occlusion inherently involves the simultaneous contact of the working and balancing teeth, and it relies on the cusp slopes on both sides. At this point, it is not understandable to verify whether the cusp slopes on the working side are identical. The jaw creates a Bennett moment on the working side, causing the mandible to move. In balancing, because the condyle dislocates downward, the angle on this side is actually steeper. Therefore, issues related to tooth contacts are not related to whether the angles are identical. In any case, there are various scenarios. What if a balancing tooth contact occurs and the working tooth contact becomes lower? Due to the balancing tooth contact, the working tooth contact becomes interfering. Situations where balancing tooth contact induces interference on the working side also occur, and when that happens, problems arise. The occlusal load increases exponentially. Eventually, traumatic occlusion occurs in the patient, prompting them to seek dental care. Of course, if the alveolar structures are healthy, this can withstand it. However, the tooth may break while enduring it. Excessive wear may occur, or the tooth may fracture. In this way, all situations act relatively. I believe that treatment should not be carried out in a manner that simply memorizes what is good and what is bad. Such a method is not good. Since the condition varies entirely depending on the patient, treatment appropriate to each situation must be applied. Anyway, I have explained the concept of such relative hierarchies. If there are no symptoms, it is necessary to determine which periodontal support is better. If symptoms occur, it is also necessary to determine whether it is a symptom of tooth fracture or a symptom of periodontal tissue destruction from a periodontal perspective. Next, it is advantageous to assess which side is superior and then establish a treatment plan. I believe in canine guidance, so all patients should have canine guidance. Patients without canine guidance are all bad, and I won't treat such patients. I cannot understand thinking like this. It doesn't make sense. And there are also people like this. Because I believe in interceptive orthodontics, I must provide it to all my patients. When the anterior teeth are worn down, leading to a group function situation, a simple method is to grind the premolars. If molars are contacting, then the molars are also ground. If the balancing teeth are contacting, the balancing teeth are also ground. Treating in this way ultimately disrupts the holding concept, causing problems. Despite suffering greatly from such issues, we still believe in that approach. You cannot perform dental treatment without learning occlusion. Because occlusion is the foundation of clinical practice, you cannot perform dental treatment without learning occlusion. We cannot discard it, ignore it, or proceed without understanding it. A typical example is that individuals who have completed orthodontic treatment neglect their occlusion, resulting in aligned teeth, but mismatched occlusion. As a result, patients may be dissatisfied with the treatment outcome. When a patient begins to complain of TMJ pain, it becomes an unmanageable major problem. Therefore, we must understand that each patient's situation is unique. The shape, position, and orientation of a patient's teeth, as well as the developmental state of their jaws, all vary. There are cases of Class 2 and Class 1 malocclusions. because even class 1 can have asymmetry. Then there's also class 3. We must respond appropriately to each situation. A crossbite in anterior occlusion leads to reverse anterior guidance. In cases of high canines, the canine cusp stands forward. In my opinion, these situations result in group function. Prior to that, in individuals with normal occlusion, canine guidance is a prime factor due to the pointed canines. There are also such cases. There are also instances of group function. When considering that the heights of the incisors, premolars, and molars are similar, it ultimately results in a balanced occlusion where one side fully contacts. As tooth wear progresses and guidance develops on the balancing side, it is referred to as bilateral balanced occlusion. In fact, this is the occlusion applied to dentures, right? The denture occlusion must be set this way to prevent the dentures from slipping. For complete dentures, bilateral balanced occlusion is the only viable method. In such cases, most patients have worn down teeth. Patients with advanced tooth wear typically exhibit group function, while those with good alignment and minimal tooth wear often have incisal guidance. Therefore, these cases are often seen in younger individuals. Since there is little periodontal disease, it is advantageous for us. However, the fact that tooth wear has already progressed, as seen in group function, indicates that the patient is somewhat older. Most are in their 40s. The reason periodontal disease occurs from that age is due to a decline in host factors. Compared to when they were younger, the body's healing capacity decreases. And when group function occurs, or the upper and lower teeth are in close proximity, food is chewed more effectively. Chewing efficiency increases. However, masticatory load also increases. Thus, in reality, the healing capacity of periodontal tissues decreases and occlusal load increases, leading many patients to seek treatment for periodontal disease, so group function is sometimes considered unfavorable. However, among patients with malocclusion, there are many young patients with group function. These patients have group function but do not have periodontal disease. Therefore, it can be concluded that the issue is not with group function, but with occlusal load and the patient's healing capacity. Among malocclusion patients, there is also a significant number with bilateral balanced occlusion. However, young individuals do not have periodontal disease. Group function ultimately increases the contact area of the teeth, thereby increasing the likelihood of periodontal destruction, especially in middle-aged and older individuals. Therefore, while such occlusion is considered unfavorable, compared to bilateral balanced occlusion, the tooth contact is reduced. Because they make more contact, they chew better. Therefore, I encourage you to carefully consider these points. When the lower posterior teeth exceed the upper posterior teeth, the upper and lower premolars' incisal tips contact in an edge-to-edge bite. Then, when the jaw is fully excursioned laterally beyond the premolars, the upper and lower molars typically provide vertical support with an edge-to-edge bite. The upper and lower teeth do not contact on their sides, but instead touch their incisal edges and move in this manner. Therefore, this is quite important. The same applies when performing anterior restorations. This applies not only to implants but also to laminates. Nowadays, there is also minish. Similar to nail art, technologies for thinly processing zirconia or ceramics and attaching them to the teeth are advancing. But ultimately, properly matching the sequential guidance is important. If the premolars providing vertical support in an edge-to-edge manner do not align with the molars in an edge-to-edge manner, everything breaks or fails. Therefore, it is extremely important. The same goes for implant prosthetics. This is a very important issue for us. It needs to be well resolved for the patient to feel comfortable. If this does not align, the patient cannot help but feel discomfort. So it would be good to study this further. This brings us back to CR and CO, which are the mandibular-centric relation discussed at the beginning. Ultimately, the jaw moves within space. The jaw moves within space. And when discussing mandibular movements in occlusion studies, we focus on the movement of the mandibular condyle within the TMJ. As you can see, there is a disc in the front and retrodiscal tissue in the back. In front of the disc, the external pterygoid muscle is pulling both the disc and the condyle head. So when the jaw opens, the condyle is pulled forward simultaneously with the disc. There are cavities containing synovial fluid both above and below the disc. As the disc moves forward with the condyle, the synovial fluid acts as a lubricant. This is the temporal bone, isn't it? This is the mandibular fossa of the temporal bone. The temporomandibular joint here is structured to protect the mandibular fossa from harmful stimuli. The knee joint is similar. If the space here continues to diminish, the disc may perforate. The disc becomes thin and continues to be compressed, causing the patient to experience pain. Especially when the condyle moves backward and compresses the rear, it puts pressure on the external auditory canal here. That is the external auditory canal, the ear opening. If the condyle continues to press here, some patients come in complaining of ear pain. This is because the moving condyle impacts the external auditory canal. And right above here is the brain. The brain area lacks sensory nerves, so it doesn't hurt. The condyle continuously impacts the brain side. Therefore, various symptoms seem to arise. Preventing such problems is the role of the temporomandibular joint that controls mandibular movement. Mandibular movement begins at the maximum intercuspal position. The maximum intercuspal position begins with the interlocking structure of the holding cusps. We refer to the process of the mandible moving and then returning to the maximum intercuspation position as mandibular motion. When viewed as a cycle, this constitutes a single cycle. The jaw is suspended in the air. The mandible is suspended from the skull, swinging back and forth like a pendulum. The temporalis and masseter muscles, followed by the internal pterygoid muscle, keep the mandible suspended from the skull. These are known as anti-gravity muscles. They maintain the jaw in a position opposite to the force of gravity. When referring to masticatory muscles, we commonly mention the temporalis, masseter, and internal and external pterygoid muscles, but in fact it's not limited to these. All the muscles around the jaw and neck, as well as those attached to the head, are involved in mastication. In particular, the neck and clavicle, that is the shoulder girdle, play important roles. The muscles attached to the shoulders work together in coordination, so we can consider the entire set as masticatory muscles. All the muscles in the neck and attached to the head are masticatory muscles. The shoulder girdle, the jaw, and all the muscles connecting the jaw and the head collaborate to facilitate mandibular movements. Therefore, it becomes quite apparent why patients with unstable jaw positions develop symptoms of systemic occlusal diseases. When the position of the jaw changes, various problems arise, including issues with the neck and airway and skull jamming. Thus, I believe that understanding this allows one to appreciate how valuable and important dental treatment is. This is an illustration depicting how mandibular movements occur. This is frequently presented in Posselt's diagram and is also discussed in gnathology. CR is located here, and the diagram depicts the maximum lateral movements to the left and right. It also illustrates the limit of protrusive movements. It really looks like a baseball field, doesn't it? This area resembles the catcher's box. This looks like the infield, and this appears like the outfield. There is side space on both sides. Mandibular movements occur in this manner, and the peach-colored area indicates the contact surfaces of the teeth during eccentric occlusion. The apex side is where the primary apex fusion site is formed. However, whether to consider this location as a point or as an area is somewhat of a challenging issue. This is habitual central occlusion. It is central occlusion, and subsequently CR is a point. From a gnathological perspective, HCO is unstable. This is because the position of CO can continuously change. If a tooth is lost or moves during orthodontic treatment, the position of central occlusion can change. You cannot establish a reference on an unstable location. When constructing, it is equally important to first eliminate instability and secure certainty. The first thing to do in everything is to establish a standard. Therefore, these individuals have negated CO. Then, by using CR as a standard, they perform condyle programming and create prostheses. Since most measure the mandibular molar using the mandibular boundary movement, the natural teeth are blunt, but the prostheses made using an articulator end up being pointed. This is because the articulator replicates the eccentric mandibular movement to shape the teeth. Even if the tooth shape is pointed, the chewing area is limited, resulting in prostheses that contact excessively. So, when placed in the patient's mouth, the patient complains that the elevated areas are uncomfortable. This is the interincisal edge contact. If the mandibular movement exceeds here, it doesn't chew. However, if you protrude the jaw like this, it usually extends only up to here. This is jaw movement, and the area where the teeth contact is ultimately this inner part. If the treatment plan is based on mandibular movements, the shape of the prosthesis is determined by the mandibular border movement. As a result, various problems arise. Patients continue to visit the dental clinic, complaining that prostheses made only with an articulator are uncomfortable, and the dentist has to keep replacing the prostheses. When such situations are repeated, the articulator is completely abandoned. They start to hesitate to use it altogether. Because it's uncomfortable, they can't continue to use it. Such occurrences happen frequently. This was a somewhat difficult topic. This is called Posselt's diagram. It's also known as the Swedish banana. Professor Posselt from Sweden, along with his students, installed pins and plates beside the mandible to map mandibular movements. Upon doing so, they found that CO is located here, and CR is situated posteriorly and inferiorly. When the jaw is pushed forward until the interincisal edge contact is surpassed, forward movement occurs and maximum mouth opening is achieved. They discovered that when the mouth is opened backward, it moves to CR, then the mandibular. Condyle undergoes rotation, and when translation occurs, it moves to the E point. They understood this phenomenon. When viewed in 3 dimensions, the spatial trajectory of the mandibular movement can be recognized, and it is visualized in the shape of a banana, although to my eyes it does not look like a banana. It is portrayed in a banana shape and called the Swedish banana. It has a somewhat witty feel. To emphasize that it is based on Swedish researchers' findings, the term Swedish banana is used. And here we have habitual mouth opening and closing. In a resting state, it is generally stated that the jaw is maintained in this position. However, as mentioned earlier, in such situations, CO can adapt by changing its position even if the jaw position changes. If this is considered unstable and centric as determined by CR, the jaw position recedes posteriorly. The results are not favorable. Furthermore, the mandibular movement from CO to CR is often referred to as retrusive guidance, whether by biting and pulling the jaw up. Swallowing saliva is the same. When biting in maximum intercuspation and then swallowing saliva, retrusive guidance engages, resulting in the swallowing of saliva. Like this. This is a natural phenomenon because CO continues to change. CO is the position formed by the occlusion of the upper and lower teeth. CR is the position of the TMJ. Gnathology emphasizes jaw movements, which led to the selection of CR based on the mandibular central position. However, that was an incorrect choice, because it is not natural. Gnathology recognized that as well. So what we did was refer to the alignment of CR and CO as organic occlusion. Feels somewhat robotic? It feels physically newly formed by human intervention. At that time, there seemed to be a lot of pride in human technology. So the deteriorating natural state is bad, meaning natural is not good. Everything changes, but they don't want to acknowledge that. Since CR is the central position of mandibular movements, and more important, they mistakenly believed it should be adjusted accordingly. As a result, it does not fit. The mandibular centric position kept moving forward and upward, back and forth, leading to a state that even they found untenable. Here it shifts by 1 to 2 mm back and forth, making it impossible to determine. Eventually they created the concept of CP, the concept of centric position. Ultimately, the mandibular centric position returned to the CO position. However, out of pride they didn't call it CO, but instead referred to it as CP. Even now, if you look at prosthodontics and terminology that adhere to gnathology standards, it is probably expressed as centric position. I don't know how it has changed recently. I recall that it was expressed as CP when I was studying. Because such important concepts keep changing, there are many aspects that are difficult to understand. Since the concept of the centric position keeps changing in journals and college textbooks, it becomes even more difficult to understand. It's because they keep teaching concepts that differ from reality. We need to correct that quickly to reduce unnecessary steps in learning. Meaningless repetition will be reduced. So if you think carefully about the Swedish banana, various concepts emerge. One of the reasons for performing Gothic arch tracing is, when viewed from the upper surface, this shape appears. This is the Gothic arch. Right, left, anterior, posterior. In other words, retrusive guidance. This allows the jaw to move in all directions. In practice, in centric relation, CR, tooth contact is superimposed. This represents the tooth morphology. This is the form of the tooth cusp. By considering this as the tooth shape and performing Gothic arch tracing without tooth contact, the CR and the lateral and anterior boundary movements are recorded. Thus, the boundaries are defined. Then, I take the CO at a certain position to establish the maximum intercuspation position. When establishing the centric position of the mandible, the form of the teeth must be visible. I am discussing the discrepancy between CR and CO. Discrepancy. The lack of alignment has a negative connotation. As the concept of distance is introduced, the intuition about tooth form. This is because retrusive guidance occurs in the transition from CO to CR, involving the mesial aspects of the maxillary holding cusps and the distal aspects of the mandibular holding cusps, right? From that perspective, I believe we should study and predict tooth morphology concepts while performing Gothic arch tracing. In the natural state, CR and CO are separated, and it seems efforts were made until the 1980s to align them, as far as I recall. Then the association disappeared and gnathology collapsed. Subsequently, with the emergence of dental specialties dealing with the TMJ and journals related to TMD, such as the Craniomandibular Journal, the alignment to CRO was ultimately concluded to be pseudoscience. It is regrettable that many still strive to treat by finding CR. It is regrettable to treat based on the principle of determinacy. Perhaps you lack confidence in treating based on the principle of uncertainty. In other words, you intend to determine the precise position of the mandible using the principle of determinacy before proceeding with treatment. Furthermore, the more you study, the more appealing the principle of determinacy in CR may become, as it aligns with providing precise treatment. Therefore, you might be more drawn to that treatment principle. However, it cannot be denied that the CO is a natural position. When measuring the patient's mandibular movements, this is indeed correct. Therefore, I hope this concept resonates more with you. I wish it would penetrate your hearts, rather than just your minds. It's right to make everything as natural as possible. Science, art, everything is based on what is natural, not on human thoughts. Science is the study of what is natural, including the laws of the universe and nature. And art is the expression of the beauty that exists in nature. However, strangely, dentistry involves too many mechanical aspects. We should follow nature. Oddly, this side is somewhat difficult. Therefore, I think it would be beneficial for you to consider this further. Here you can see the Gothic arch tracing of mandibular movement. However, there is a Gothic arch for each holding cusp and also for the TMJ. The Gothic arch records mandibular movements. Mandibular movement refers to the movement of the lower teeth. Next, the TMJ moves. Ultimately, mandibular movement means that the lower teeth connected to the mandible are moving, and both mandibular condyles that constitute the mandible are also moving. Those movements are represented by the Gothic arch. When viewed in 3 dimensions, the Gothic arch is quite impressive. You need to grasp the spatial dynamics of these mandibular holding cusps in movement. The movement of the mandibular cusps is similar. However, the maxillary holding cusp does not move itself. Instead, the occlusal surface of the mandible moves. Therefore, you need to consider the relative movement of the maxillary holding cusp on the mandibular occlusal plane. When the concept of Gothic arch tracing is combined with mandibular movements, many aspects, including tooth morphology, become visible. Thus, when this beautiful 3-dimensional Gothic arch shape integrates with tooth morphology and the structure of the TMJ, many things become apparent. Being able to discern the invisible is a remarkable ability. People involved in commerce or the arts also deal with the unseen. The pantograph and functiograph of the TMJ are all represented by the Gothic arch. When the 3-dimensional space in which the maxillary holding cusp moves becomes visible, you gain incredible capabilities. Ask the patient to engage their teeth and to grind them. When you observe the patient making occlusal contacts or performing mandibular movements, the Gothic arch should be visible. Once the invisible begins to become visible, remarkable abilities emerge. In the occlusal space, the circle denotes centric, while the arrows represent protrusion, laterotrusion, and retrusion. When you can observe all of these, a new perspective will emerge. The process of recognizing these phenomena is not easy. The process leading to awareness is difficult. However, with continuous observation and effort, these will become apparent. Not only the holding cusp, but also the non-holding cusp moves. The occluding maxillary holding cusp also moves relatively. This constitutes the occlusal plane. If you understand the spatial forms formed by mandibular movements, you can immediately determine where to reduce, where there is deficiency, and where more form needs to be created. The patient's discomfort, necessary treatments, analyses, diagnoses, and treatment plans are all based on that. One day I suddenly thought, I must seem a bit odd, but I came up with the idea of the one mandibular concept. Why is that? In mathematics, there are terms like singularity and ideal. They originate from Euler's notation. There's also the natural constant A. Although the mathematician Euler conducted research on many topics, one area he explored involved mathematically determining whether shapes are the same or different. So I borrowed a term from that field. I understand that field to be topology. We consider circles, triangles, and squares to be different, but in topology, they are viewed as the same. If you leave a rubber band as it is, it has a circular shape, but you can stretch it to make a triangle, a square, and various other forms. Then, from a topological perspective, they are the same shape. We consider whether it is a homotopy or homology, and the term Euler characteristic is also used. Mathematics can be complex, so I'll leave it at that. For those who are interested, please explore further. So to conclude, the shapes of these teeth are all different. As we move forward, the angles of the triangles increase, and as we move back, they decrease. If it tilts to one side, the angle on the tilting side widens, and the angle on the opposite side decreases. The same applies. When it comes to the TMJ, the Gothic arch is transformed into the shape of the TMJ. However, ultimately, depending on the position, the Gothic arch, that is, the movement pattern of mandibular motion, differs. However, like the concept of topology, I consider the tooth shape that matches mandibular movement as normal and others as abnormal. I view them as the same shape. Some people ask if that makes sense. It does, because it was measured at different positions of a single mandibular movement. It was recorded from multiple positions. There is only one mandibular movement. It's just that the shape changes depending on the position. Looking at the content, this is one form of mandibular movement. Therefore, it is identified as the same shape. That's how I determine it. I view them as the same shape topologically. Thinking of them as the same shape has simplified many things. Due to occlusal wear, that is, due to tooth wear, the tooth shape is deformed. If I put a crown on top of this, I have to define the form of prosthetic restoration. Furthermore, you should consult with your dental technician and make a decision on that. What degree should we set the cusp angle for prosthetic restorations? Should we determine the cusp angles as 23 degrees, 25 degrees, and so forth, based on the TMJ angle? That doesn't make sense. Adjacent teeth and this tooth should have the same morphology. Moreover, the teeth in front, as well as those preceding them, both anterior and molar teeth, should also possess the same morphology. This is because the anterior teeth are either worn to a similar extent or maintain an overall consistent shape. Before understanding this, I made many unreasonable mistakes. If you want to perform prosthetic treatment well and fabricate prostheses using an articulator, the adjacent teeth, posterior teeth, the opposing side, overall, all the teeth are worn down and look dull. Only the prostheses I made were fabricated to be sharp. I think I made such an unreasonable judgment thinking, why did I do it this way? All I needed to do was to make the shape of the prostheses flat. As I studied occlusion, I started to consider the angle of the TMJ as important. As a result, I began to prioritize the TMJ. Because all the occlusion textbooks say so, I couldn't deny that. In the end, I think I made many mistakes because of that. There was also a case like this. It was a situation where I did tooth preparation on mandibular teeth for prosthesis. And a similar situation occurred when performing full mouth rehabilitation. If you leave the anterior teeth and place a partial denture in the posterior edentulous area, you end up doing a surveyed crown. When making a removable denture, you have to redo the surveyed crown. Natural teeth are all worn down. Next, denture teeth have a different form compared to natural teeth. As a result, 3 different forms exist in the mouth. Therefore, the patient ultimately cannot adapt. At that time, I couldn't understand. The centric concept is important, and then there's the eccentric. Continuously being misled, teaching in that manner, and having learned that way. I was only thinking about those things. Later one day, I suddenly noticed that an abnormal form was being created in the mouth, not the standard anatomical shape. Of course, it's not adapting well. Since then, I have realized a lot. There are many seemingly sophisticated discussions about the TMJ. They talk about academic aspects and claim it's scientific, but in the end, a single standard emerged. It means that an abnormal form cannot coexist within the mouth. To perform prosthetic restoration, a standard form must be created. When we provided our dental technicians with articulators, they want to use the cone technique in wax-ups to create marginal ridges, precise tooth shapes, and aesthetically pleasing prosthetic restorations. However, the form of the occlusal surface is usually plain. The shape of the adjacent teeth is also plain. So, as I go along, I tell them not to make an effort, just place the wax and then push it out. Then, after making it similar to the adjacent teeth, I instruct them to properly form the fossae and grooves. Next, I instruct them to accurately replicate the form with an emphasis on the cusps. When I explain it this way, the dental technicians don't fully believe it. I aspire to be a proficient technician who diligently studies to create impressive prosthetic restorations. But by saying it that way, they must have felt I was implying they were making things carelessly. However, producing it in that manner is not doing it carelessly, but doing it correctly. In the meantime, you have learned about articulators, TMJ, mandibular movements, canine guidance, cone technique, and such. In the oral cavity, ideal forms cannot coexist mathematically or scientifically, so we need to create a static form. That is the mathematical proof. When expressed like this, it may not be understood, so there are cases where heads are tilted in confusion. Even now, you probably won't believe it. However, since it is correct, it cannot be denied. If these things are well communicated and understood, what we call unrealized aspirations, it may feel like waking up from a futile dream. I had followed that futile dream for about 20 years. At one point, I fully grasped this concept, and incorrect thoughts were shattered, inducing self-deprecating feelings, and I couldn't believe it. All that effort was meaningless. I also thought such things. After accepting the concepts of static form and ideal form, I feel much more at ease now. Our dental clinic also has a centric relation articulator. We also purchased a pantograph. I had employed various methods, but at some point I decided to abandon them. It appears that I have advanced significantly in a more mathematical and scientific direction. Therefore, the one mandibular concept has been immensely beneficial to me. There is a German design group called Bauhaus, and this is their catchphrase. It conveys that form follows function. The one mandibular concept I mentioned earlier is itself a form. We must design the shape of the teeth based on the function of mandibular movement. We cannot arbitrarily create the form. What the Bauhaus design group often does is functionally design the forms of items like chairs and desks. It's about design. They frequently use the term ergonomics. Those concepts haven't been around for long. Therefore, the concept of functional form is more relatable. In this context, by carefully considering both eccentric and central occlusal forms, you can logically assess tooth morphology. And continuing the discussion on eccentric occlusion, we cannot avoid talking about overbite and overjet. The relatively higher eccentric occlusal contact causes the relatively lower contact to disengage. Those who have relied solely on canine guidance up to now will not be able to understand this concept. In my view, eccentric occlusal contact and canine guidance are merely differences in relative heights. It's simply that the relatively higher tooth causes the relatively lower one to guide, but explaining it using angles made it complicated. And it seems you have studied the influence of the TMJ. Although I couldn't understand it, I thought and believed it was right. One day I suddenly realized that even this wasn't correct. What I mean is molars are large and incisors are small. However, if you divide them into cusps, ultimately, the capping of the entire dentition is determined by the interlocking of holding cusps in the maxillary and mandibular teeth. We refer to the vertical overlap as overbite, and we call the horizontal clearance overjet. Both overbite and overjet exist. Molars have 3 or 2 holding cusps, followed by 2 non-holding cusps. So the tooth shape is large, but the overbite is small. Molars have their shape divided by cusps, and the shape of incisors is determined as a single unit, which makes the overbite relatively larger compared to molars. However, incisors undergo rapid axial inclination, and molars have a gentle occlusal slope. The overjet of incisors decreases, and the overjet increases proportionally toward the molars. Additionally, the overbite increases in the anterior teeth and decreases as it moves toward the posterior teeth. Thus, the overjet is smaller for the anterior teeth and larger for the posterior teeth. The opposite is true for an overbite. A large overbite in the teeth is the primary factor causing the overlapping of smaller teeth. Next, a small overjet in the teeth is the secondary factor causing the overlapping of teeth with larger overjets. These two factors combine so that, due to mandibular movement, the areas with greater inclination come into contact relatively first. Teeth with steep angulation make contact with the lower teeth later, resulting in eccentric cusp contact that causes lateral displacement. This occurs sequentially, which is why it is called sequential guidance. I believe the issue of which teeth contact and cause relative lateral displacement relates to overbite and overjet. With this concept established, it becomes evident that guiding eccentric cusp contact is a choice. Next, it became possible to understand why eccentric cusp contact varies among patients. Naturally, that is correct. Through this process, I have embraced the diversity of eccentricity, from my perspective. Therefore, even among my own patients, including those with deciduous arches, I encounter various cases. In deciduous arches, occlusion often involves unilateral or bilateral balancing contacts. This is because the incisors are small and there is spacing between them. The overbite of the incisors is minimal. Of course, there are class 2 cases in deciduous arches. There are also class 3 cases, and various occlusal forms exist, but in cases of orthognathism and Angle's classification class 1, bilateral balanced occlusion of the molars commonly occurs because the incisor overbite is typically small. When the permanent dentition is well aligned, incisal guidance is prominent. During the mixed dentition phase, flat deciduous teeth coexist with pointed permanent teeth, which can be considered a malocclusion. After the permanent dentition is completed, if the teeth wear down, occlusion progresses to group function. Subsequent tooth wear leads to changes in occlusion, progressing to unilateral balanced, bilateral balanced, and fully balanced occlusion. If teeth are lost in the meantime, it results in malocclusion and pathologic occlusion. There are days in dental practice when all these processes are observed within a single day. From elderly patients to children, we witness the diversity of occlusions all in a single day. However, if one insists that only incisal guidance is correct, believing solely in incisal guidance, treatment cannot be performed. It becomes nonsense. Therefore, I believe that asserting that only incisal guidance is correct is not acceptable. However, I believe that eccentric occlusion cannot be resolved solely by overbite and overjet. From our perspective, the occlusal plane is more important. There are the inclination, curvature, and orientation of the occlusal plane. You saw earlier in that image that the occlusal plane was canting, right? There is inclination and curvature. Next, there is the orientation of the occlusal plane. Because the anterior of the occlusal plane can tilt downward, and the posterior can tilt upward. When looking at the inclination of the occlusal plane from the front, it can be considered the slope of the occlusal plane, but the orientation also needs to be considered. The inclination of the occlusal plane pertains to the slope of the occlusal plane located between the maxillary and mandibular jaws. Therefore, you need to accurately determine whether it is an issue of position, slope, or curvature of the occlusal plane, and quickly assess how the occlusal plane affects the contact and intercuspation of eccentric occlusion teeth. Of course, you must also be able to perform the analysis. The maximum intercuspation position is formed regardless of the slope, curvature, or orientation of the occlusal surfaces. However, the contact and canine guidance do not behave the same way. During mandibular movement, when tooth contact occurs between the maxillary and mandibular occlusal surfaces, they are influenced by the slope, curvature, and orientation of the occlusal surfaces. There are various discussions related to this, but there are only a few basic principles. Firstly, symmetry issues are often considered. Symmetry. Symmetry is the prime factor, and there is the concept of balanced front and back. Most animals, including humans, exhibit bilateral symmetry. There are no asymmetrical organisms. Some may say, flatfish, like flounder and halibut, are asymmetrical. That is an exception related to survival. They have adapted to their environment. They have evolved to suit their environment. Therefore, those situations should be considered exceptions. Most animals are fundamentally symmetrical, and their tails provide balance. Thus, there is a front and back. The temporomandibular joint also maintains balance. When the jaw moves due to mandibular movements, the TMJ in the back is providing a counterbalance. You can understand it that way. There is occlusion in the front and counterbalancing in the back. Next, there is proportion vertically. When we look at people, we observe body proportions like 8 heads tall, 9 heads tall, etc. Distinguishing them in that way is the principle of design. The occlusal plane can slope downward or upward towards the maxilla. In cases where it slopes upward, class 3 is more common, and when it slopes downward, class 2 is more prevalent. However, this varies for each person and cannot be precisely defined. Only by analyzing, assessing, and diagnosing according to the individual can proper treatment be administered. In this photo, there is a discussion about overbite and overjet. As you move toward the anterior teeth, the overbite increases. As you move toward the posterior teeth, the overbite decreases, proportionally and relatively. The overjet decreases toward the anterior and increases toward the posterior, relatively and proportionally. This is a summary of the content. In the absence of tooth wear, canine guidance is the prime factor and the prime occlusion. It is a dominant occlusion. It can be considered a dominant condition. As tooth wear occurs, it progresses to group function and balanced occlusion. In such circumstances, I consider the curve of Spee. This is a reverse curve of Spee. In this case, due to mandibular movements, it contacts more anteriorly and posteriorly. When the teeth move, the middle contacts less. It is pathological. Then, I attempted to flatten the curve of Spee. The middle would make more contact. I restored the curve of Spee to normal and then significantly accentuated it. There are quite a few patients with such cases. In such cases, anterior overbite increases significantly and tooth contact occurs in various areas, including group function. These reverse curves of Spee vary among patients. Especially in the case of the curve of Spee, some patients have separate anterior and posterior curves of Spee centered around the premolars. There are patients in whom the anterior curve of Spee increases and others in whom the posterior curve of Spee increases. There are various patterns. This involves altering the inclination. It can be increased or decreased, but that is an orientation issue. When the posterior of the occlusal plane is lowered, posterior tooth contact becomes stronger, and when the anterior is lowered, anterior tooth contact becomes stronger. Recently, I came across an orthodontic technique called rampa. It is a technique developed by Japanese dentist Mitani Yasushi. He has implemented this method, and it is also widely used in orthognathic surgery. When performing a Le-Fort eye osteotomy to advance or set back the maxilla, the outcomes differ depending on whether the posterior or anterior maxilla is moved downward, and the stability of the surgery varies significantly. It seems that he uses a device called rampa to elevate either the posterior or anterior maxilla. In doing so, he reconstructs the occlusion. This is orthopedic treatment, orthognathic treatment, and involves issues of growth and development. It is a matter of determining the direction for the growth and development of the maxilla, and as a result, even when the central occlusal plane is established, the eccentric tooth contacts change. Occlusal issues are more complex. We cannot predict how occlusal reconstruction will occur. Although this individual's TMJ angle is such, from an occlusal perspective, it is explained in terms of incisal guidance relative to the occlusal plane. When the anterior descends and the posterior ascends in this manner, condylar guidance decreases and incisal guidance increases. The incisors continue to make contact. In angles class 2, If the mandibular arch is moved anteriorly, assuming the mandible follows, and a new occlusion is formed, having the anterior of the occlusal curve descend would be somewhat disadvantageous. Conversely, I believe that raising the anterior of the maxilla and lowering the posterior of the maxilla would be advantageous. This is because more of the maxillary incisors are visible. Then the mandible follows forward and does not recede backward, which I think would be beneficial. In the case of class 3, the incisors are smaller, opposite to class 2. Additionally, the growth and development of the maxilla are less advanced. I believe that by protruding the maxilla or the maxillary dental arch forward, raising the posterior part of the occlusal plane and lowering the anterior part will be advantageous. I have considered up to that point. I think that orthognathic surgery and the rampa technique should also be considered from an occlusal perspective. Next, the curve of Spee is also important. If these factors are not harmonized, functional occlusion cannot be formed. Orthopedic orthodontics and orthognathic surgery are processes or techniques of treatment themselves. Regardless of the treatment performed, achieving occlusive stability is necessary for good treatment outcomes. I hope you will delve deeper into this matter. Dentists who use template therapy for TMD treatment believe that the occlusal plane passes through the center of the odontoid process of the second cervical vertebra. They also consider that the geometric structure formed by the intersecting design of these three circles, creating Borromean rings, maintains the balance of the head. One of the circle positions is near the glabella. I don't know the anatomical landmark for the center of this other circle. Sometimes it's discussed in connection with the skull base. There are 3 circles. They are called Borromean rings. We sometimes explain using this geometric structure. I don't know it in detail. Treatment could involve removing or adding the maxilla, but it seems that this approach is not commonly used for the mandible. In orthopedic orthodontics, it was concluded that chin cups have limited treatment effects, and the maxilla is a soft bone compared to the mandible. Because of membranous bone growth, it moves significantly under pressure, so these treatment methods were devised. Since the condyle undergoes cartilaginous bone growth in the mandible, it seems that it cannot be controlled by force. Therefore, in the past, attempts were made to inhibit mandibular growth by using methods such as chin cups, but were abandoned. When suppressing mandibular growth did not work well, treatment was started in the direction of promoting maxillary growth. So in the end, some people choose rampa. That's also the correct method. Currently, orthodontic techniques aimed at inhibiting bone growth do not seem to be attempted. We treat hypergrown jaws, and it has been concluded that there is no method to reduce jaw overgrowth. When the mandible is overgrown, I believe that treatment plans which move the maxilla forward to match the overgrowth are not appropriate. I think performing orthognathic surgery is the correct approach. It seems that maxillary overgrowth is not very common. Membranous bone growth is inherently induced during the process of dispersing stress or occlusal load resulting from occlusal forces. Cartilaginous bone growth appears to be an intrinsic growth process. It is greatly influenced by hormones. If growth hormone continues to be secreted from the pituitary gland, as seen in patients with acromegaly, where growth hormone continues to be released even after growth has ended, growth hormone is the cause. This results in an enlarged forehead and jaw. This is referred to as terminal symmetry, and even the fingers become significantly larger. Fingers also thicken, and it seems that cartilaginous bone growth occurs at each joint of the fingers. Cartilaginous bone growth is greatly influenced by hormones, while membranous bone growth can be explained by mechanical theory. Membranous bone growth is affected by loading or stress. The growth direction and amount of development are determined. Therefore, those performing rampa or orthopedic orthodontics must also choose the direction of treatment. If the jaw continues to grow, it is not possible to align the maxilla to the enlarged mandible. Therefore, I believe that orthognathic surgery can also be a good method. There are quite a few individuals who gave up practicing orthopedic orthodontics because they couldn't resolve inconsistencies at this point. It seems that many have failed because of the high complexity in practicality and accessibility. And the next reason is that if mandibular growth continues, it cannot be resolved with rampa. So I think many were disappointed there as well. Still, there are dentists who believe that treatment can be done with a chin cup and continue to use it to this day. There are also individuals who have been monitoring treatment outcomes for 30 years. Earlier, I discussed membranous bone growth. I believe that increased cartilaginous bone growth due to the influence of growth hormones is not an indication for rampa. Therefore, a more cautious and scientific approach is necessary. This is a photograph of a full denture patient. I set the orientation at the center between the maxilla and mandible as much as possible. Then I adjusted the inclination of the occlusal surfaces. As a result, it fitted exquisitely like this. I may have intentionally drawn this diagram, but it has become an important point for me. In order to determine whether I am providing correct and scientific treatment, I conducted this research. When viewed from the front, the occlusal plane also has a significant impact. It greatly affects eccentric contacts and canine guidance. You can see this by arranging the overbite and overjet on the occlusal plane. A larger overbite causes a smaller one to disocclude. The relatively higher side disoccludes to the relatively lower side. When viewing the occlusal curvature from the front, it is Wilson's curve. Wilson's curve affects eccentric tooth contacts and canine guidance. If there is canting in the occlusal curvature, it is a matter of slope. The occlusal plane can slope upward or downward toward the maxilla. To control this, treatment methods such as rampa are important. The principle of rampa treatment is to apply traction to the teeth to pull the maxilla, right? There is a clutch that holds the maxillary teeth on the maxillary occlusal plane, which can apply torque, inclination, or even forward traction through it. I haven't used rampa, so I'm not familiar with its lateral applications. The concept of treating with rampa involves changing the slope of this occlusal plane, because occlusion has a significant impact on rampa and orthopedic orthodontics. When expanding the maxillary arch and mandibular arch for tooth alignment or performing extractions, Wilson's curve is continuously altered. Then, the guidance for working and balancing cusps changes. We must understand how this affects the system and complete orthodontic techniques from an occlusion standpoint. Dentists still lack understanding of the occlusal surfaces. When performing various dental treatments such as orthodontics and prosthodontics with a sufficient understanding of occlusal concepts, the treatment outcome of the overall occlusion is generally determined by how the occlusal plane is established. It cannot be expressed by tooth contact alone, because the position of the jaw has shifted. The balance has been disrupted, causing some kind of issue. There are treatments available in such situations. Without incorporating the occlusal plane in the treatment process and outcomes, it cannot be explained. Even with orthodontic expansion, expanding the maxilla increases the Wilson's curve. Expanding the mandible results in a reverse Wilson's curve. However, there is only the concept of expansion. Therefore, there is an expansion method called RPE. Performing rapid palatal expansion inevitably increases the maxillary Wilson's curve. The mandible tends to collapse, resulting in a significantly deep Wilson's curve, which might suggest a proper occlusion. However, discrepancies in arch width prevent achieving correct occlusion, necessitating mandibular expansion as well. Expanding the mandible leads to a reverse Wilson's curve in the lower arch and deepens the maxillary Wilson's curve, ultimately causing misalignment. Additionally, discrepancies arise in both the upper and lower arch widths and in the occlusal surfaces. So how can this be resolved? After expanding the maxillary and dental arches, processes such as managing relapse or applying orthodontic forces to adjust occlusion must be added to complete the orthodontic treatment. When the Wilson's curve increases in this manner, balancing forces become stronger. If a reverse Wilson's curve occurs, working forces become stronger. Furthermore, increasing the inclination of the anterior teeth causes the mandible to continue recoiling backward. There is a possibility that the mandible may need to be repositioned backward or forward. Therefore, without adjusting the Wilson's curve, it is impossible to achieve a new occlusion. Because the amount of the Wilson's curve is expressed as a circle, it is often expressed with a 4-inch spherical model in the glabella. Whether it is symmetrical or not is determined by a geometric analysis of the vesica piscis formed when circles are drawn around both condyles and overlapped. The geometric shape formed by two circles of the same radius intersecting each other is called the vesica piscis. They slightly modify it and draw it like this. Many things can be understood. Therefore, this kind of analysis and diagnosis is necessary. However, most diagnoses are based on numerical values. They only look at how many or what angle of inclination it is. Some clinicians diagnose through proportional drawing. An example is the Sassoon cephalometric analysis. I find the Sassoon analysis to be more reliable. Everything else is based solely on numerical values. They set a normal range of values and define it as incorrect if it falls outside that range. Each person's skull shape and occlusion are different, so setting a standard range is not appropriate. That cannot be explained with that. It is more important to collect occlusal information that varies by ethnicity and create big data. Currently, orthodontics set normal value ranges based on Caucasian standards, resulting in a high number of extraction cases in East Asian populations. Especially among black individuals, bimaxillary protrusion is much more prevalent than in East Asians. If orthodontic treatment is performed, it involves 100% extractions. Therefore, establishing standards for orthodontics without considering racial differences is nonsensical. These errors are leading to various problems. The tweed technique has been adopted in the country, but it appears similar errors are being repeated there. Because I am not very familiar with the tweed technique, I can't assert that it's wrong, but that's the impression I have. So in my case, I only refer to the tweed analysis as a reference. I do not use it as a standard. I have analyzed it based on the principle of proportion. In my opinion, dental analyses should also apply proportional measurements. So when I drew it coincidentally, the center forms a vesica piscis shape. When I constructed circles from both sides, it was drawn like this, and the lower jaw is the same. This does not mean it is the only correct way. Every patient has different cases, and there are various proportional scenarios. With this, I diagnose extraction versus non-extraction and determine the extent of non-extraction expansion. I perform cephalometric analysis to diagnose the direction to proceed. By collecting such data, we will be able to provide more accurate dental treatment. It's not a matter of which is right or wrong, but rather the need to recognize biological diversity. Orthodontic treatment ultimately divides into extraction and non-extraction. We need to consider which approach is more advantageous. We must deliberate whether non-extraction expansion is more favorable biologically, or if the decision to extract offers aesthetic benefits. Aesthetically, extraction orthodontics provides social benefits. However, there may be biological and functional drawbacks. We must weigh each disadvantage and advantage before making a decision. Expanding the maxillary arch and performing non-extractive orthodontic treatment is biologically advantageous, but it can be aesthetically and socially disadvantageous. You must consider all of these factors when deciding whether to extract or not. You should not unilaterally impose treatment on the patient. Carefully weighing these factors and making a judgment is a challenging issue. We have covered the relative heights and depths of occlusion. The relative heights and depths of occlusion can be explained by the fence theory. If the maxillary arch restricts the mandibular arch, the fence, that is, a larger maxillary arch, restricts the mandibular arch more extensively. When the maxillary fence increases, a class 2 occlusion is formed, and the jaw is pushed posteriorly. If the maxillary fence is small, it cannot restrict the mandibular arch, resulting in a class 3 occlusion. This content is borrowed from a fence theory paper. The fence ultimately refers to overbite and overjet, and relates to arch discrepancy. When I explain to my patients, I use the analogy of a rice bowl and its lid. The rice bowl lid must be large enough to cover the bowl. For patients with a narrow dental arch, I suggest expanding the maxilla. In cases like class 2, the maxilla is large and the mandible is small. In such cases, we need to grow the maxilla so that the mandible can protrude forward. The jaws are large, but the dental arch is small, which is constraining the mandible. In such cases, we perform dental arch expansion. Instead of using RPE, performing slow expansion on the teeth alone and expanding only the dental arch will cause the mandible to move forward. When the mandible moves forward, the mandibular arch becomes relatively larger. In doing so, the mandibular arch also expands primarily around the teeth and alveolar bone. This thereby aligns the arch discrepancy. I prioritize treatments that balance the upper and lower arches based on the fence theory, and then arrange the teeth accordingly. This is one of my patients who came to me after undergoing implant surgery at another clinic. As you can see, it is clear that they were somewhat improperly placed. Due to using screw-type implants, the periodontal tissue was destroyed because of micro-movement of the abutment. He has a deep overbite in the anterior teeth. Despite having a class 1 relationship, lateral forces were applied, causing the surrounding tissues of the implant to fail to withstand the load. Additionally, ongoing inflammation developed and calculus accumulated. Unfortunately, I had no more advice to offer the patient. The patient is aware. The implants were placed elsewhere, but the orthodontic treatment was performed at my clinic. There has been a serious increase in clinics that are dumping patients lately. Such dental practices lack responsibility. The patient hasn't returned since then, so I'm not sure how things turned out. I believe there might have been issues with the adjacent teeth as well. Therefore, you need to understand the concepts of overbite and overjet. And as you can see, red indicates centric tooth contact, while blue indicates eccentric contact. These aspects need to be thoroughly studied. This patient is a high canine case. Implant treatment was performed in this manner. The overbite of the premolars has been eliminated. Consequently, the remaining teeth have developed an overjet. This tooth does not have an overbite. There, the relatively higher tooth guides the relatively lower one into lateral movement. However, since their heights are similar, the first molar actually guided the mandibular movement instead. The premolar became lateral, and the second molar also became lateral. Balancing side tooth contact cannot become lateral. Because the premolars have descended, and more mandibular movement is required for balancing to become lateral. The opposite side is the same. Here, the first premolar is somewhat prominent, causing the second premolar to erupt, and similarly, on this side, it has also slightly erupted. Balancing occlusion cannot be achieved in this case. Therefore, there is no choice but to adjust it this way. We trust in canine guidance, but we cannot treat with canine guidance alone. And I believe this is a case that illustrates this well. When attempting buccal guidance up to the premolars and molars with an edge-to-edge bite, only the balancing occlusion makes contact. Therefore, the other teeth remain supraerupted. The opposite side is the same. Protrusion is the same. By looking at it this way, you can determine which tooth is higher. You can assess the relative height differences. This relative height difference is the most important, and other factors are not significantly important. This patient has a narrow maxilla, a mandibular overbite, meaning the maxilla cannot cover the mandible. An arch discrepancy occurs. The maxilla should be about 10% larger than the mandible, but that is not the case. In such cases, occlusal adjustment is ineffective. It is an edge-to-edge bite and an arch discrepancy, and ultimately, all occlusal contacts are centric as well as eccentric contacts. In this situation, lateral displacement of teeth cannot occur. Balancing is also present to a very slight extent. When performing protrusion, see that the premolars are slightly raised. Premature contacts have occurred here, creating space between the teeth. Looking at it this way, we can explain the entire occlusal situation. Understanding these concepts means that knowledge has been acquired. By repeatedly reinforcing this understanding, it becomes ingrained, enabling you to perform high-quality treatments. In fact, it's not possible to distinguish between centric and eccentric tooth contacts. Moreover, these holding cusps share centric and eccentric tooth contacts. Only in the occlusal surfaces are centric and eccentric tooth contacts separated. Holding cusps themselves constitute both centric and eccentric tooth contacts. You need to understand this concept. If you reduce this when it's high, centric tooth contact disappears. Since it's a canine, it might be preferable for the centric tooth contact to disappear. We have much to learn by examining such cases. This patient is a friend of mine. The mandibular left second molar has an implant. That posterior area has the implant. I recommended adjusting it because the occlusal surface was uneven, but he refused, so it wasn't done. Anyway, since the implant isn't contacting, there's no risk of it failing. As you can see, this part is the highest. It's relatively high. This area gets caught. Then, the area between the tooth root and the alveolar bone fractures in a V shape. Because the alveolar bone is being held and the teeth continue to bend due to occlusal forces, the cervical area undergoes an indirect fracture. A stress fracture is called abfraction, and it occurs due to eccentric premature tooth contact. As you can see here, the relatively higher area occludes against the relatively lower area. This patient has strong occlusal forces. He chews well. The centric occlusal contacts are making very strong contact. However, they do not contact during eccentric mandibular movements. Therefore, this will last for a long time. In fact, centric tooth contact is not a major issue. Centric occlusion is not a significant problem, but eccentric prematurity is an issue. So despite discussing various aspects, the most important point is that the relatively higher area occludes against the relatively lower area. Ultimately, sequential guidance has to be adjusted. Next, the occlusal surfaces, curve of Spee, Wilson's curve, Mobius curve. If the maxillary anterior is in lingoversion and the posterior is in buccoversion, the occlusal surfaces of the premolars become twisted. The inner and outer surfaces of the occlusal curve have been reversed, making it similar to a Mobius strip. Hence it is called a Mobius curve. Holding cusps move along the occlusal surface. So, you need to adjust this uniformly using the plate and pin concept to achieve good harmony. Thus, you need to uniformly adjust the height of the holding cusps and the occlusal surfaces, which results in various types of eccentric guidance, proportionally. So it can result in canine guidance, group function, unilateral or bilateral balanced occlusion, or fully balanced occlusion. Therefore, the concept of uniformity was more important. Additionally, factors such as the size of the arch in the occlusion, the relative sizes of the maxillary and mandibular arches, the shape of the teeth, and their relative heights and levels must be considered. There are also overbites and overjets. Furthermore, the curvature, position, and inclination of the occlusal surfaces combine to establish the patient's unique eccentric tooth contacts and canine guidance, and you need to ensure it contacts as uniformly and sequentially as possible. Once everything is aligned, there is one final important point. Higher areas should be reduced. Lower areas should not be reduced. You should reduce areas that are relatively high. Therefore, perform eccentric occlusal adjustments to create a uniform guide and a consistent occlusal surface. Since the holding cusp involves both centric and eccentric tooth contact, you must already adjust the height of the holding cusp when aligning the centric occlusion. If there are protrusions or mismatched heights on the upper and lower occlusal surfaces, it will inevitably cause issues with eccentric tooth contact or guidance. Thus, by properly aligning the centric occlusion, the eccentric occlusion will be nearly correct. Align more than about 90% and adjust the remaining occlusal surfaces to create a uniform guide. We inform patients that even if only these protrusion areas are removed, they will feel more comfortable. Using this method, you can perform eccentric occlusal adjustments without major problems. Today we covered the topic of eccentric occlusal adjustment. Next is the maximum-minimum rule, which is sometimes also called the minimum-maximum rule. Today we learned that there are many possible cases in occlusion. We realized that no single occlusion is predominant. Next, the comparison of tooth morphology and position, as well as the relative comparison of the maxillary and mandibular dental arches. By combining various occlusal relationships, centric and eccentric occlusions are determined. We must carefully assess which is advantageous or disadvantageous. Occlusal adjustments can involve various methods, such as reducing or adding teeth or prosthetics. Therefore, we need to interpret diverse patient occlusions, and in the next session, we will explain the necessary concept of the maximum-minimum law and conclude the lecture on implant occlusal adjustments. Today, I discussed eccentric occlusal adjustments, and I hope you understood without any misunderstandings. I also have no prejudices. Furthermore, preconceived notions and prejudices are different. Preconceived notions can change, but prejudices do not. They never change. If you consider this without prejudice, I believe you will receive this information positively. Thank you for your efforts today. We will conclude the lecture on eccentric condyle occlusion adjustment here. Thank you.